Thank you very much for this opportunity to talk today. And I'm always extremely grateful to be able to present work in front of Grace and its larger community. So this is a long title, and I can really summarize this in about 5 or 6 words, which was the original title, which is how can we use radiation to improve outcomes and quality of life in patients with metastatic lung cancer. These are my disclosures. And so at the end of the day, I would make the argument that our medical oncology colleagues and our preclinical colleagues have done an amazing job at increasing the portfolio of medications and drugs that really make a powerful survival impact on our advanced lung cancer patients. As you can see, this study, that was really one of the early integrators of immunotherapy and chemotherapy versus a placebo and chemotherapy. And so, the real idea was that there was really benefits, but, always trying to do better and trying to do better for our patients. We realized that over time, these curves reduced in terms of overall survival percentages. And so what we need to do as a group and what we need to continue to do is to better understand how to make these drugs work more durably. And I think part of the explanation of why we're still not optimizing our approaches is, in general, lack of predictive and prognostic biomarkers. And this is a little bit of a dated slide, but I still show it because it still suggests that a majority of our solid tumor cancer patients, including non-small cell lung cancer patients, don't have a very durable response to frontline immunotherapy. And so it begs the question of, what more can we do to optimize these outcomes for our patients? And as Dr. Bazanova was just pointing out and looking at our waterfall plots, you always notice that the waterfall plots go from shortest response to longest response. But each one of those represents potentially a patient. And what that means to me is that there's an extreme variability in how effective a systemic therapy is. And this slide presents the same exact information. As you can see in the red box, this is a progression-free survival on first-line EGFR inhibitor osimertinib. And you see that 4 patients have the exact same exon 19 mutation, yet you see a vastly different response to the first-line therapy, with some of the patients having progressive disease, whereas others have disease that extends, progression-free survival that extends beyond 50 months. And so that variability would point to both tumor intrinsic biology, maybe co-occurring mutations, maybe other biology that we haven't really thought about or are in the process of thinking about. It also talks about the potential for our host biology, meaning, how our immune systems respond to a tumor, how our immune systems respond to a therapy that really dictates how we optimize outcomes. And so what you've heard earlier from even earlier today is the idea that now every stage of non-small cell lung cancer is really a ripe opportunity to treat all stages of cancer with every single treatment modality, whether it's systemic therapy, by pill or infusion form, by surgery, and by radiation. So as a field, we need to better understand how to integrate all of these different modalities in whether it's a sequencing question, whether it's omitting one or adding a therapy to optimize how we do best for our patients. And so the idea of using local therapy in the form of radiation and surgery for metastatic patients is actually, people think it's a relatively new one, but I'll show you that there was efforts to do this way back in the day. But why has it become more important and more relevant in the last few decades? It's basically what I just described. With modern systemic therapies, its utilization and availability are more obvious. These systemic therapies are doing better and better, but are still not perfect and cannot stand alone. And with modern diagnostic tools that allow for the detection of early metastatic disease, can we add local treatments in some settings of advanced disease to optimize our therapeutic outcomes, in either making our patients' disease curable or at least chronic, in which case they live for a long period of time, but we have to keep coming back and treating every so often. Other evidence that supports local therapy was the fact local therapy beyond palliation. Local therapy in the form of radiation has been used in palliation for many, many, many years. But to use it to try to improve survival outcomes is what we're really talking about today. And one of the important points to notice is that when patients have stage 4 lung cancer and they have first progression, usually the first sites of progression are in the original sites of gross disease, which would indicate to us that if we could somehow use a local therapy at these original sites of gross disease to facilitate the systemic therapy in controlling progression, then these patients may have a much improved progression-free survival interval. We can also take experiences from our surgical colleagues who have historically, for metastatic diseases like sarcoma and for colorectal cancer, have removed lesions that have spread to the liver, for instance, that have spread to the lungs, for instance, and even the brain to optimize a survival outcome and not just a progression-free survival outcome for different patients.